Yeah, so I talked a little bit about the newfound food flexibility that sometimes goes along with the transition from multiple daily injections or non automated pumps to automated insulin delivery. This is by no means something that happens in all individuals. But one really interesting effort that's being undertaken at Stanford University is an ancillary study that was just funded as part of a postdoctoral fellowship that Dr. Marian Talbot obtained as part of her work with Dr. David Maas. And so, as part of that 4T study that comprehensively intervenes on diabetes management from the time of diagnosis, they're also, working on introducing automated insulin delivery systems as close to the time of diagnosis as possible. And Miriam, on top of that, or Dr. Talbot, is going to be intervening on diet quality simultaneously. And the reason for that is that, carbohydrate counting has kind of been the end all be all of the dietary management of type 1 diabetes for a long time. But I think there's growing recognition that there needs to be a greater emphasis on overall diet quality. We know that diet quality is as low in the population with type 1 diabetes as it is in the general population. So if we think about something like the Healthy Eating Index, which measures adherence to the dietary guidelines for Americans. On average, people with type 1 diabetes are scoring between a 50 or a 60, which out of 100 is unfortunately not a high grade. And so there's really an opportunity there to intervene to sort of prevent some of the potential weight gain that can occur after the transition to automated insulin delivery. The other thing is that, of course, continuous glucose monitoring, especially in type 2 diabetes, has been used as a behavior change tool to actually promote weight loss. I think because it is a staple of type 1 diabetes management sort of from the time of diagnosis, that may or may not apply sort of as readily. But ultimately, we can talk with our patients about monitoring blood glucose responses to foods, thinking about how that might, increase insulin needs, and ultimately knowing that higher insulin requirements in some people, if it's in the context of excess caloric intake, can lead to weight gain. Yeah, so we talked a little bit about diet quality just now. I think the other points that you're making are also very important. I talked about insulin resistance as a part of overall cardiometabolic health. The interesting thing that you mentioned that I think we know very little about is satiety in type 1 diabetes. We know that generally higher fiber intake, which is lacking in the diets of lots of Americans, including people with type 1 diabetes, is a primary contributor to satiety, both due to sort of the direct bulking effects of fiber that slow gastric emptying, can also help with blood sugar management, and can also promote a beneficial milieu of gut microbes that promote the release of satiety hormones like GLP-1, which can, act centrally to reduce appetite. I think those are all really interesting sort of general recommendations that we would apply, but things that might be relevant in type 1 diabetes as well. Um, we know very little about satiety hormone signaling in type 1 diabetes, which I think could be very relevant for weight management. We don't know, for example, if gut-derived hormones like GLP-1 or PYY are different in people with and without type 1 diabetes. We might think that they could be just due to sort of gut differences in gut health and gut motility in people with type 1 diabetes, as well as differences in the composition and the function of the gut microbiome. And the other thing that I think is worth mentioning is that those mechanisms are sort of part of a homeostatic hunger or satiety signaling, where we think about, physiologic indications that we're actually hungry and in need of more food. The other side of that coin is hedonic eating or hunger, where it's not really a true physiologic hunger. It's more of kind of like a head hunger, is how some people describe it, where, it could be a craving due to stress. And there's some suggestion, although mostly clinical anecdote, that people with type 1 diabetes have a dysregulated sense of hunger due to the need to prevent and treat hypoglycemia. So things like the fear of hypoglycemia might cause some people to get hunger and fullness signals misconstrued. But again, it's kind of an open area of research, and I think it's definitely something worth investigating, especially as GLP-1 receptor agonists become more readily available for this population, because it's possible they might help to restore some of that normal homeostatic and hunger signaling. Yes, so we talked about several of those. The two that I don't think we touched as much on are the last two. The first is the gastrointestinal side effects. So this is a hypothesis. I don't know that there's a huge amount of literature to support this, but it certainly is conceivable that incretin-based therapies that slow gastric emptying could actually cause more GI distress in people with type 1 diabetes, particularly those people who struggle with gastroparesis. And so that is something that, of course, healthcare providers should screen for or be aware of prior to prescribing these medications, and then, of course, monitor very closely. What we don't want happening is that somebody feels so sick that they're not able to consume enough food, because that leads into your second question about, or your last point about nutrient sufficiency, which is that if weight loss occurs too rapidly, not only is excess lean mass lost, but the risk for micronutrient deficiencies increases by a lot. We talked earlier about the fact that weight is only one indicator of health. So just because someone drops a lot of weight, it doesn't mean that they're more metabolically healthy. So we want to be using multiple indicators of health, including potential, even if we can't measure muscle mass directly in the clinic, we of course want to be checking in with patients to make sure they're eating adequately, working with a registered dietitian on eating fewer, more frequent meals if that helps to alleviate some of the GI distress. And then, of course, trying to maintain physical activity levels to kind of, aid in lean mass retention, and specifically um, engaging in resistance exercise at least a couple of times a week. Yes, they should. I'm glad you pointed that out. Yes, I think those endpoints do need to be included in all studies related to weight management and type 1 diabetes, and not just weight management, but trials related to metabolic endpoints in general. I think if a research institute or institution has the capabilities, some additional measures we could think about adding are, you mentioned body composition, so not just DEXA, but also MRI, because it's really valuable to be able to measure organ fat. So ectopic fat deposition in the liver or the skeletal muscle, which are two big indicators of cardiometabolic risk. Um, if a clinic that is wanting to conduct research is not highly specialized and doesn't have those kinds of expensive tools readily available, I think that bioelectrical impedance analysis, BIA, sort of those machines that you hold by the hands and then stand on barefoot, those could be reasonable ways to assess body composition as well. They are more sensitive to changes in hydration and being fasted versus fed, but they are quite reliable. So even if they're not fully accurate, they can be okay at measuring changes in fat and lean mass over time, especially if someone is sort of, doing those measurements under the same physiologic conditions each time. So fasted, no caffeine, etc. And then the most basic sort of cost efficient type of measurement that can help to reveal changes in body composition during an intervention is waist circumference, which is a good measure of central adiposity, and again, closely correlated with cardiometabolic risk factors. Another one is the hip, waist to hip ratio, or the waist to height ratio. So I absolutely agree. The final one that I'll mention is the estimated glucose disposal rate, which is a marker of skeletal muscle insulin resistance. And it's the estimated glucose disposal rate because there are equations that have been developed using commonly obtainable clinical measures like hemoglobin A1C, waist circumference, age, etc. And there are actually online calculators where clinicians can now plug in the data of a participant to estimate their insulin sensitivity. And again, looking at changes over time over the course of intervention may be useful.